This is Dr. Anuj Shah, the Director of Apex Heart and Vascular, and I'm very excited to tell you about the updates leading into 2026 in the world of cardiac and vascular disease. You won't believe how quickly the field of cardiology has evolved over the past year. When we shared last year's update, we talked about how our tools are getting sharper, from safer radial access to better calcium-modifying technology and the rise of long-acting lipid therapies. What's striking now is how much further the evidence has pushed us since then. This year's data don't just refine what we do, they reshape the pace and depth of how we intervene. I'm Dr. Anuj Shah, and here's what clinicians need to know heading into 2026. Firstly, in the field of interventional cardiology, the biggest shift this year is the clear advantage of physiology-guided complete revascularization in multivessel disease. The FIRE trial in elderly patients showed that when we use pressure or flow wires to guide complete PCI, we reduce the composite of death, MI, stroke, or repeat revascularization by roughly 27% compared with culprit intervention only with hazard ratio of 0.73. The effect held even amongst high bleeding risk patients. This fits perfectly with what we emphasized last year, which was safer access, radial better than femoral, better calcium preparation like intravascular lithotripsy, and more strategic stent optimization. Together, they will build a stronger foundation for complete revascularization to be default and not the exception. The stent technology continues to improve as well, with ultra-thin, bioresorbable polymer DBS platform showing extremely low thrombosis rate. And IVUS and OCT have now crossed the threshold from useful to essential. Across multiple data sets, imaging-guided PCI matches or even outperform angiography-only PCIs, especially in multivessel disease and complex lesions. The 2026 interventional message is simple. Radial access, lithotripsy when needed, intravascular imaging, and physiologically guided complete revascularization procedure has the best outcomes. What about structural heart disease? In structural heart disease, the TAVR durability continues to impress. 5-year data from the Evolute low-risk trial now show no significant difference in death or disability in stroke between TAVR and surgery. 15.5% versus 16.4%. The valve performance, the gradients, and reintervention rates remain excellent and comparable. In the mitral space, the momentum is just as strong. The ENCIRCLE study evaluating the SAPIEN M3 transcatheter mitral valve in non-surgical patients showed 12.9% mortality at 1 year, which is fantastic, 16.7% heart failure hospitalization, and 95% of surviving patients with trivial or no MR at 1 year. Last year, we also talked about the early groundwork for transcatheter mitral therapy or TMVR. This year's data show that we are well past the groundwork. We are already seeing surgical level results in these patients who are otherwise not a surgical candidate. What about electrophysiology? Electrophysiology is also entering a new phase defined by tissue selectivity and fewer leads. The pulse field ablation or PFA dominated 2025. Systems like Pulsar and Omnipulse delivered fast, clean pulmonary vein isolation with excellent safety, and early studies are now extending PFA into ventricular arrhythmias with the field force catheter. On the pacing side, conduction system pacing continues to outperform the traditional CRT therapy. Data from the high-class registry show that CRT with left bundle area pacing reduced the combined endpoint of death or heart failure hospitalization to 20.5% compared with 29.5% for conventional biventricular pacing, showing significant improvement of left bundle pacing. Defibrillator therapy is changing with the Praetorian Excel trial showed that subcutaneous ICDs had major device complication of 5.7 compared with 10.2% of transvenous ICDs at 8 years, showing the superiority of subcutaneous ICD, which is minimally invasive device, very consistent with our Think Small campaign. The same shift we saw last year in interventional trial is what we are seeing in the world of EP, safer tools, less trauma, which is now truly accelerating the field of electrophysiology. What about heart failure? Heart failure therapy continues to broaden and strengthen. SGLT2 inhibitors remain foundational, and early inpatient initiation gains more traction with each dataset. In DAPA-ACT heart failure trial, the dapagliflozin started in hospitalized patient with heart failure showed reduced composite endpoint 10.9% versus 12.7% with trends similar to other early initiation studies that we saw. The biggest breakthrough in heart failure this year comes from the remote hemodynamic monitoring or the Monitor heart failure trial. The Monitor heart failure trial demonstrated that 44% relative reduction in heart failure hospitalization, which translated into major improvement in quality of life. So remote monitoring is now something we strongly recommend. We have devices and tools like CardioMEMS, which can help with minimal invasive procedure to get pulmonary pressure monitoring. The FDA approved and broad coverage of the pulmonary artery pressure monitoring is now an evidence-based option for patients with recurrent heart failure admissions. And remember, Vericigua, the soluble vinyl cyclist simulator we spoke about last year for high-risk HFrEF patient. The new real-world data reinforced more than 10% relative risk reduction in heart failure hospitalization when is added to rest of the guideline-directed medical therapy in patients who are recently decompensated heart failure. What about lipid management and lipoprotein? Lipidology may have the most dramatic change of all in 2026. The Vasilius cardiovascular trial demonstrated that adding the PCSK9 inhibitor evolocumab in high-risk primary prevention patients reduced major adverse cardiovascular events by 25%, with median LDL falling to 45 milligrams per deciliter, and heart attack risk fell by roughly 36%. This builds directly on what we touched on last year, that PCSK9 therapy is moving earlier in the prevention pathway. Inclisiran, the twice-yearly siRNA agent we highlighted last year, continues to deliver durable LDL reduction also, and is increasingly used to improve adherence in high-risk patients. Even more transformative, the Coral Reef trial of the oral PCSK9 inhibitor enlicitide showed that 56 to 60% LDL reduction at 6 months, plus a 28% drop in lipoprotein A. An oral drug with those numbers would reshape adherence and access completely. For the lipoprotein A, the RNA silencing drug lipodesiran produced staggering result with 94% reduction at 6 months, 89% still reduced at 12 months with a single dose. So very soon we're going to see groundbreaking changes in the LPA management. And finally, a first-in-human CRISPR therapy targeting anti-GPTL3 showed that it cut LDL by roughly 50% at 60 days with one injection. This is the CRISPR technology, a hint of what one-time genomic therapy could mean for lifelong risk. So as we head into 26, the theme is very clear. Our tools have matured and the evidence has finally caught up. Last year innovation, whether it's lithotripsy, radial access, vericiguat, inclisiran, PCSK9 therapy, weren't just trend, they were the beginning. This year's trials show how powerfully those tools perform when fully integrated into modern practice. At Apex Heart and Vascular, our focus is simple: turn this evidence into immediate real-world benefit for our patients. Thank you so much and wishing you an amazing 2026.